In this video, we will be discussing about atrial fibrillation. The most important part in atrial fibrillation is recognizing the ECG and the treatment. The treatment part is most important because it involves various flowcharts and algorithms. So it is very important to understand the diagnosis and treatment part of atrial fibrillation. Definition. Definition of atrial fibrillation. It is a cardiac arrhythmia originating from the atria, which is characterized by disorganized and rapid atrial electrical activation, which leads to disorganized and rapid atrial mechanical contraction. Right? Disorganized atrial electrical activity, eventually leading to atrial mechanical contraction, which is again disorganized and very rapid. It is the most common sustained arrhythmia. That is why it is a major public health issue. Now the patterns of AF or how the AF can present in different patients. It can be paroxysmal, which is very short lasting, and the duration is less than 7 days. Means atrial fibrillation occurring on its own and terminating on its own, occurring several times a day, but the duration is less than 7 days. From last 7 days, the patient is complaining of shortness of breath, fatigue, and palpitations, and or chest pain. This is paroxysmal AF. Then comes the persistent. The signs and symptoms are similar. The difference is it is persistent, means the episodes, they are not only the episodes of AF, it is continuous AF which is occurring in this pattern. Means there is continuous palpitation, continuous fatigue and dyspnea, and maybe continuous chest pain which occurs in the patient, and we see on the ECG that he is having atrial fibrillation, and the duration is typically 7 days to 1 year, means less than 1 year. Persistent continuous AF duration less than 1 year is categorized under the persistent AF. Now the long-standing persistent AF means the duration is more than 1 year, otherwise everything is similar to persistent AF. Now the treatment part of AF is most important. Suppose the patient comes to you with acute onset of AF. Means patient is complaining of syncope, means not complaining of, patient is complaining of palpitations, dyspnea, and chest pain, and he is having episodes of syncope, and the duration is acute, means he is suddenly experiencing these signs and symptoms. You have to see whether the patient is stable or he is unstable. If he is unstable, cardioversion is imminent. We have to do cardioversion. We have no other choice. Cardioversion using electrical methods means using an electronic device. We do QRS, synchronous shock, DC shock, right? Chemical or pharmacological cardioversion can also be done by using ibutylide, which is a class 3 antiarrhythmic drug. If the patient is stable and the symptoms are acute, we have to consider rate control. We have to control the ventricular rate, because if ventricular rate is controlled, then proper filling and time for recovery of myocardium will occur. Means we will have adequate time for recovery and adequate time for filling. For these purposes, we have to do rate control. After we do rate control, we have to do anticoagulation because of the risk of CVA or thromboembolism to uh, cerebral circulation. mainly middle cerebral artery. To prevent CVA, we have to do anticoagulation. After we do anticoagulation, if you want to consider cardioversion, why cardioversion? Because we want to control the rhythm. रिदम कंट्रोल करने के लिए हम कार्डियोवर्जन कंसिडर करते हैं. We do rate control. Rate control is must. We have to do rate control without any compromise. After rate control, whether to do cardioversion or whether not to do cardioversion is a matter of choice. Is a matter of symptomatology of the patient. If the patient is symptomatic, if the patient has a risk of heart failure, if the patient has paroxysmal AF, if the patient has recurrent and persistent AF, you have to consider cardioversion. Once you wish to do cardioversion, then you have to look at the duration of the atrial fibrillation. Whether the symptoms are less than 48 hours or it is unknown duration or it is more than 48 hours of AF. So these two scenarios are different and their further management is also different. Let us consider the treatment on the basis of duration. If the duration is less than 48 hours, and there is no risk of thromboembolism, there is no risk of valvular disease, there is no CHF, right? You can do imminent cardioversion without anticoagulation. पेशेंट आया, आपको पता है कि इसको एफ आ रहा है, आपका नॉन आपका मतलब इट इज अ रिपीट patient of yours and the patient is complaining of signs and symptoms, you do ECG, you find AF, you can do cardioversion without anticoagulation, right? But if there is risk of thromboembolism present, means if the patient is in heart failure, if the patient has valvular disease, right, or if the patient has uh, PTNR is, I mean, if there is any other risk of thromboembolism, then you have to do anticoagulation first. After anticoagulation, you can do cardioversion, right? So this is the treatment approach which is used in AF of less than 48 hours duration. If AF is more than 48 hours of duration or we do not know the duration of AF, we have two options with us, right? More than 48 hours or unknown duration, we have two options. First is you have to do anticoagulation for 3 weeks, you do cardioversion and you continue anticoagulation for next 4 weeks at least. Though we have to do anticoagulations for lifelong, but for next 4 weeks you have to definitely continue. Second approach is to first do transesophageal echo to look for LA appendage thrombus. If there is no thrombus in LA appendage, right, you do cardioversion and do anticoagulation for next 4 weeks. And if you have LA thrombus, then you do anticoagulation and you keep on looking for the uh, dissolution of the thrombus. It will take, I think, maybe 3 to 4 weeks before you go for cardioversion, right? Then you will basically use this approach. Do anticoagulation, cardioversion, continue anticoagulation if there is thrombus, right? If there is thrombus, if thrombus is there. If thrombus is there on transesophageal echo, then you do this approach, right? So these are the two options if more than 48 hours duration. So this is all about the treatment of acute onset of atrial fibrillation. Now we have to do acute rate control in patients with AF. That is what we discussed in this flowchart. Stable patient we do rate control. How do you do rate control? Now we will consider how to do rate control. This is how you do rate control. We use beta blockers or we use non-dihydropyridine calcium channel blockers. Beta blocker is basically metoprolol. Non-DHP means dilsem or verapamil, right? Chronic rate control means once you have a control of the rate, how do you do the rate control for long periods of time? We do use the same drugs, or a third option that we have is catheter ablation of the AV node to cause permanent AV block. But then you will have to put a permanent pacemaker. Permanent pacemaker implantation. This is known as ablate and pace strategy, right? Mainly we use drugs. Ablate and pace is not accepted by many patients. That is why we do use the drugs uh, more often than not, right? Now, how do you do stroke prevention in atrial fibrillation? We use Chad's-Vasc criteria, Chad's-Vasc score. This score will tell us the risk of thrombosis, right? Why do we do risk of thrombosis and embolism in AF? More the score, more the risk. If the score is more than or equal to 2 in females and more than or equal to 1 in males, we do anticoagulation. How do you do anticoagulation? Of course, we give aspirin and no, novel oral anticoagulants, that is direct 10 inhibitors, right? That is apixaban, rivaroxaban, edoxaban, and dabigatran. Dabigatran is 2 inhibitor, but we can also do this comes under the category of NOACs. But remember, this is only non-valvular AF. If there is valvular AF, then you have to use warfarin along with aspirin, right? This is very important. This is a multiple choice question asked multiple number of times. Rhythm control is considered in patients that I have previously told you. It is it is considered in patients with symptomatic AF, paroxysmal AF, or recurrent AF, or in patients with risk of heart failure. We use rhythm control strategy. How do we do use rhythm control? First of all, we can use drugs, and second is we can do catheter ablation. Drugs, if there is no structural heart disease, no CAD, no heart failure, we use class 1 antiarrhythmic drugs. Class 1 antiarrhythmics are basically sodium channel blockers. What are the drugs? These are flecainide, propafenone, diisopyramide. Flecainide, propafenone, and diisopyramide. And if structural heart disease is present and CAD or heart failure is there, we do use class 3 drugs. What are the class 3 drugs? It is dofetilide or sotalol. But these dofetilide, dofetilide, but these drugs, they cause QT prolongation, right? So they can induce ventricular tachycardias. But we do use them judiciously, keeping their therapeutic index in control. We use these drugs. Catheter ablation can also be done, and it is a proven strategy that is better than the drugs because the drugs they can cause their toxicity and their side effects. And catheter ablation is a proven strategy to control rhythm in patients who are treated previously or who are not treated previously for atrial fibrillation. Catheter ablation has proven its role, right? It is better than drugs. So, recapping the whole lecture once again. Atrial fibrillation, first of all, definition, then patterns of AF, three patterns: paroxysmal, persistent, and long-standing persistent. Treatment: for acute onset of atrial fibrillation, if the patient is unstable, you have to do cardioversion with electrical method or with chemical method. If the patient is stable, do rate control first of all, then do anticoagulation and then consider cardioversion. For considering cardioversion, consider duration. For duration, you have to look for whether less than 48 hours or more than 48 hours or unknown, right? These two are in same category. If unknown duration or more than 48 hours, two options. First of all, do anticoagulation, then do cardioversion, then continue anticoagulation. Second is do transesophageal echo, look for thrombus. If no thrombus, do cardioversion and then continue anticoagulation. If duration is less than 48 hours, no risk of thromboembolism, you can do cardioversion. Risk of thromboembolism, first do anticoagulation, then do cardioversion. Right? Less than 48 hours is you have to do cardioversion most of the times. Right? You can do cardioversion to control rate and rhythm most of the times. Right? Then stroke prevention. Chad's best criteria is used. Score more than 2 in females, more than equal to 1 in males. Do anticoagulation with aspirin and NOAX in non-valvular and aspirin plus warfarin in valvular. Rhythm control done in symptomatic paroxysmal recurrent risk of heart failure. Methods are drugs. If no structural heart disease, class 1. If structural heart disease, class 3. Second method is catheter ablation, which is better than drugs. So that is all about the atrial fibrillation management. I hope you have learned a few things. Thank you for your patient listening, and I will be coming up with the new video.